I know this is the first session after lunch, so the energy levels may be a little different to the morning sessions. But as you can see, we've got a very august panel here with us right now. We have Dr. Reddy on video. Dr. SNP Singh should be joining us shortly, President IMA, on the video as well. And I'll kind of, the session we are here to talk about today, you heard in the morning about ABDM, how ABDM is looking at changing the lives of every patient. And I think I really liked one example which came towards the end, that patients are carrying a bag full of records whenever they go from one hospital to to another hospital. And if they forget to carry something, they've forgotten to carry. And a doctor, and we were just talking to Dr. Soy, and he said in a complicated disease, that bag can become a trunk full as well. So I think in one very simple way to look at ABDM is, can that bag go away? And can that data be available in a digital form? And so that some meaningful use can come out of the data as well, and doctor can benefit, patient can benefit, and the entire ecosystem can benefit. I think that objective was explained quite well. The program is at a very interesting cusp right now. So obviously something as large a change as this is, it will take its time. But we saw one interesting graph with Dr. Sharma presented in the morning, which was the actual number of health transactions, the way they've started to grow. The first 100,000 taking some 500, 600 days, and the next 1 million taking whatever, about 90 days or 100 days, and the next crore, or the 10 million, taking less than a month. I think that's the pace at which the records have started to grow. Which means that the inhibitions around this is going away. And probably I think that brings to the topic of the session today, which is about how all the various stakeholders in the ecosystem need to work together to make this work. And if I give the same analogy of UPI, which has been talked about extensively in the morning, the NPCI and RBI together created the rails. NHA has done the same. But now all the banks and all the providers and all the aggregators in between came in between to kind of provide the services on top of that. So these are the stakeholders. From a hospital standpoint or from a health system standpoint, the stakeholders, obviously patient being at the center of it, hospitals, doctors, labs, tech providers, government, all of them are very important stakeholders. So what we've managed today is to get together kind of a group of 7 people who represent each of these aspects of the stakeholder group extremely well. And I'll kind of not spend a lot of time in introducing everyone together in the beginning. I'll do it as kind of each of us start to make their interventions. So I'll start with, and kind of hand over the mic to the chair for the session, Dr. Manohar Agnani. Dr. Manohar Agnani needs very little introduction in this room, especially in the health space, as the Additional Secretary in the Ministry of Health and Family Welfare. Obviously a medical doctor, master's degree in international health from the University of Copenhagen, joined the IIS in 1993. And I think he's been spearheading some of the major reforms in the Ministry of Health and kind of digital. He puts it very crudely, but I can see the passion in the digital coming back from him. So your opening remarks and your interventions to start with.
Thank you, Neil. So we heard in the morning how National Digital Health Mission is doing wonders in last 1 year. And we witnessed the opening presentation where Dr. R.S. Sharma was saying that it is citizen friendly, and how there is access to discover, book and avail health services. CoWIN is an excellent example, and if I have to say in the recent past, if you have to see something, you visit CoWIN, how it can change, it has changed the entire dimension. And now it is being used to universal immunization program. Another examples would be tuberculosis, we are using for the Nikshay portal. Similarly, teleconsultations during COVID is another great example through e-Sanjeevnis. And we heard the IT minister also in the morning who was saying that government is working hard towards creating three vital requirements, which is connectivity, public digital goods like CoWIN, UPI, and a robust regulatory framework to ensure privacy, security, and data sharing algorithms. And just 2 more minutes, we had a recent Chintan Shivir on all the tertiary care hospitals we have in the country. All AIMS and other hospitals participated. We had a session on ICT, and where the consensus which emerged was that ICT should aim in a sequential manner, keeping the patient satisfaction first. Then we should move to the electronic health records, then of course the telemedicine, subsequently other things like Wi-Fi campuses and the e-libraries, etc. But we know the National Digital Health Mission is coming up with the creating continuous longitudinal digital health records, and we have the registration of doctors and other paramedicals also begun. We are coming with the health professionals registry, and here not only the doctors but allied health professions also we should keep in mind, because we tend to ignore them while discussing health professional registries. And all this will eventually can lead to use of electronic prescription. There was consensus that teleconsultations should be a strong medium, but for the follow-ups to begin with. And referral chain is very, very important from primary, secondary to tertiary. And also, if you really want to close the loop using this IT-enabled solution, you have to think about the reverse referral mechanism through these IT systems. So as Dr. R.S. Sharma was saying, that efficient and effective solutions in finding interoperable open. So open API-based, open source-based, open standard-based solutions which are inclusive and have nationwide IT solutions for the convenience and harmonized use of technology in the delivery of services. So we have another examples. We heard about the e-rupee also in the morning and other things also. But just a last minute, we are coming out with the medical value travel. We, you must have heard about the Heal in India concept, and also trying to serve the global community by providing our health professionals another concept which is Heal by India. And if we really want to make these a reality, there would be many solutions. So we have rich stakeholders, not only on this side, but stakeholders on that side also. I will stop here, and being chair of this session, I will try to regulate all the speakers with their time limits. Thank you.
Thank you. Thank you, sir. I think as we broadly, I think the way we try and run it is that we'll try and, I think one of the learnings we had from the earlier sessions was not enough time was left for the discussions. So we'll probably just have one brief round with everyone and then open it up for questions for a very long amount of time, as many questions as everybody has, and then try and come back to the panel to complete the other parts of the question. And I think I'll start with, as I said, we've got each of us here representing a different ecosystem stakeholder. I'll start with Dr. Sangeeta Reddy. I think needs no introduction as a global healthcare leader, as the co-chairman of, joint managing director, of Apollo Hospital, and very clearly representing the large organized tertiary healthcare ecosystem in the country. So ma'am, the question which I had for you, yes, we all realize ABDM is a mega change happening in the country. And there are various perspectives regarding advantages, disadvantages, challenges, benefits of adopting a system like this. So what do you think, ma'am, are and I think one of the additional benefits is that a large tertiary hospital typically has already done automation. I think in the earlier session, we also heard about Dr. Gera, I think that DG NIC was talking about it, that the back end is done. So if the back end is done, you just need to get it on the digital rails there. So all tertiary hospitals have typically done that. So what do you think, ma'am, are the reasons why a large hospital should come or why they are not coming on board, really forthcoming and coming. So let me put you on a bit of a spot and get your views on it.
So good afternoon, and let me begin by saying it's a pleasure to be connected and extremely not apologetic, but so much I'm feeling bad for myself that I'm not there to hear the extent of the conversation. And in the introduction, while you describe us as a large criteria, I think because we also have clinics, we have an online presence, etc. And has been one of the evangelists for the connected healthcare environment. So very passionate about digital healthcare. The recommendations in the early report from Mr. Satyanarayan on moving from EMR to PHR and really creating that continuity with actually a suggestion that came from us, because 9 years ago we started our PHR, we currently have over 8 million records within our ecosystem. So I am very much an advocate for this. I believe that doing it through the Ayushman Bharat Digital Mission, we then connect different players, not just within our ecosystem, which was actually our original intent, and we have a few other hospitals who joined in with us at the future. So conceptually, I'm extremely happy about it. Coming back to the benefits, I think everyone in the room probably knows the benefits, but it's important to re-highlight that there are benefits both at the patient end as well as at the hospital or the healthcare provider. From the patient side, I think the ability to not just, they don't have to carry their files or their suitcases or papers, but beyond that, they don't have to re-explain to every doctor, starting from their history. And from their GP to their tertiary care to and coming back again. So that ability to have a continuous view of the patient record and do it conveniently is, I think, one of the biggest. From that, the second level of outcome, which I think is very critical also, is to enable doctors and healthcare professionals to operate at the peak of their license. So if things are well documented, you don't have to replicate. And if this file is available, the nurse knows what to follow up. You do it in a structured manner, and you juxtaposition this to the standard treatment guidelines. And you include not just the doctor, but the entire care team. Then the efficiencies of the overall ecosystem for the patient as well as the provider is going to be greatly enhanced. I'm also extremely happy that your concept of the digital health mission is including the claims portal. Because another large area for us, so besides the operational side of the financial side, and once again for a customer, we all know that a cash patient can get discharged in half an hour to 1 hour, but the insurance patient is sitting in the hospital for 3 to 5 hours waiting for this. So if we can enhance that, we're removing pain points, which is extremely critical. And finally, and most importantly, we're all here from the medical aspect of it. From a medical perspective, the ability to not just build standard treatment guidelines, which are enabling the best of care to get systematized, but also the follow-up factors. To give a clear description to the general practitioner for a patient post-evaluation visit. You can be sure that GP is ensuring that there is a medication compliance, and you don't have that patient coming back in with a blocked or a blocked valve. So there are multiple medical use cases which enable us to say very clearly that a continuum of care, a proper documentation, standard treatment guidelines, and involving the patient or the family member in the treatment, because this care is available to them extremely easily. Plus, of course, operational things like now all of us are trying what is called from patient-reported outcome measures. We want to know, who recovered faster, post-delivery placement, did you walk on the third day, did you walk on the fifth day without pain. Gathering this data in a call center while waiting for a patient to come back to the doctor's office and ask these questions and then document them is not as easy as having a PHR where the patient inputs this data, and this is also calculated in the appropriate
Absolutely. I think that is a very good lead segue to get into the next conversation, I think, which I'd like to pick up from here. And Dr. Rizwan Koetar sitting right next to me. So just a brief introduction about himself. Rizwan set up his own kind of health tech company much before, I think, at least in India, health tech had come up and was probably one of the first health tech unicorns, Citius Tech, coming from India that way. But I think a couple of years ago, probably the philanthropy bug got him excited as well. So he sold all of that and now co-chairs the Koeta Foundation, which is doing a fair amount of work on the cancer side with IIT Mumbai, of which he's an alum as well. I think just Rizwan, taking the point which Dr. Reddy said about now, it's about how fast the adoption can happen. And we all know for a faster adoption, having the intermediary tech products is going to be an absolute necessity. So what are the, if we look at from that standpoint, that stakeholder group having developed a product there, what can be done? How can they kind of really excite this entire ecosystem? And especially you worked extensively in kind of overseas markets around this as well. So any learnings coming from that as well? And do keep it brief, because as the chairman sir has instructed, we'll go back to questions right after this.
Yeah, thanks, Neil, and really appreciate being here today. So thank you very much to NHA and to the group here for attending a session on a Sunday afternoon. I appreciate that. Let me take the question to keep it brief. I would say let's just look at digital transformations in India, which have actually worked very nicely. You look at the Aadhaar and the UPI. And the reality is that it got adopted very easily. It got adopted very easily not because every Indian understood what the UPI framework was and the underlying technology was. But the reason UPI and Aadhaar became so popular was because the platforms or software or applications, whatever name you want to call it, adopted the use of Aadhaar and UPI into their applications and made it completely seamless to the common man. So today a common man goes and uses UPI ID. They only need to know, अरे ये आपका जो banking application है इसमें आप press कीजिए, आपको QR code दिखेगा, आप QR code कीजिए और फिर आपका 4-digit password डाल दीजिए, आपका चालू हो जाएगा. You know, it's literally as simple as that. And we have taken away the entire complexity of what authentication layer there may be and what data gets transferred from bank A to bank B and what kind of security and privacy norms are being used. In the same way, I believe that one of the biggest enablers of the ABDM program is going to be healthcare technology companies integrating ABDM so seamlessly into their workflow that whether you're a doctor or you're a nurse or a lab or even you're a patient or even a regular Indian citizen, the fact that there is the ABDM platform working in the background should be completely oblivious to the person. It should become like, अरे वो तो इतना simple है, वो 2 minute में, अरे आपको नहीं आता है, मैं बता देता हूँ. It should be literally as simple as that. So our success in rolling out the ABDM program is very closely hinged with technology companies doing a great job of adopting and making it really simple. The second part of the question, I thought Neil you asked me, was what does it take? So imagine I wear a hat of technology vendors. I know there are many technology companies here. What would motivate me to put in the right kind of money and investment in supporting ABDM with all my focus, all my attention, all my time, all my money? And if I wear that hat, I would say I have a few asks. My first ask would be that let NHA and the ABDM team standardize the process of what I need to get done so that it becomes easy for me to sit down with my product development team, with my product team and saying, okay, now this is the requirement. Now let's make it simple and let's make it happen. The second thing I would expect is that there should be a certification program so that once I cross a certain, I put in the time, effort, money, then there should be some organization that gives me a badge. And that badge should become very visible. I should be able to use the badge in my marketing material. It should be there on my website. Perhaps it should even be on the NHA website or some other website as an approved product, because that gives me the marketing clout that I need to become successful. The third thing I would expect is that the government in some ways should nudge the buyers to give me preference if I have made the investment in becoming ABDM compliant. So whether it is a government RFP, it should, if not compulsory, it should be highly recommended that yes, if you're buying a certain product, whether it's an HMIS product or a LIMS product or some other product, at least make it preferred that, with software vendors or software companies who have been certified are going to get a certain, preference in the approval process. That gives me confidence that if I have made the investment, then I have a better chance of winning my next customer. And finally, I would say that if the government can even provide certain benefits, some financial benefits, I know we are not a rich country like some of the countries in the US and Europe who have spent a significant amount of money in implementing and actually government paying hospitals to do it. Perhaps we don't have those kinds of monies, but through intelligent use of the PMJY scheme or intelligent use of certain reimbursement mechanisms, creates some financial incentive which will enable hospitals to be more motivated in buying an ABDM approved solution or a solution that has ABHA integration. I think if you just think about all these different factors from a perspective of a software vendor, I think that'll be tremendous. And one final point I'll make and pass it back to you is that what we must recognize is that when a software vendor incorporates something, it by default becomes available to all their entire install base. So while it may seem onerous to go to hundreds of thousands of physicians and trying to explain them ABDM and tens of thousands of hospitals and trying to explain them ABDM, the reality is there are probably going to be 25, 50, 100 software vendors who are going to be catering to this large pool of doctors and hospitals. If you could target 50 of those software vendors and just convince them to accept it and embrace it, their influence and leverage on these hundreds of thousands of entities around the country is actually very large. So I do feel that software vendors and software tech companies are going to play a very critical role in the rollout. In fact, I would probably go one step further. I would say that the rollout can only happen if the software healthcare tech community really embraces it. In the previous session, they spoke about human-centric design. Human-centric design, nothing but making it so simple that the end user doesn't even know that ABDM is being used. So I think that should be a benchmark, that we should be able to roll out ABDM without having to use the word ABDM with any doctor or hospital. If we can achieve that, then it will be pretty amazing. Yeah.
I think, sorry, before I pass on, I must respond to some of the asks as the kind of only representative in a way from NHA. See, I think you said 4 things. First was some sort of a certification and getting that thing ready. Second was about a nudge. And third was about kind of financial...
SOPs, certificates.
SOPs
first, certificates second, financial incentive third. And fourth again was
nudge and trying to make that work. So sir, I think from a certification standpoint first, you sit on the board of NABH as well, and NABH has been entrusted by NHA to provide free certification. So Government of India, NHA is going to pay the money for the first set of X number of whatever health tech products which come out in the next 1 year or so. All of them would be provided a certification by NABH free of cost at the cost of the government, so that this quality certification comes in. So that's a program which has been approved and people have started to benefit. NABH and QC have started working on that. So your point second in terms of the nudge. So one thing which is probably over the next 1 month or so should complete, all the products which are kind of integrated with the ABDM, they should get a listing on GEM. That's the government e-marketplace. People who are familiar with the government would know. which is a preferred place for procurement by any government institution. So there an empanelment is being supported by NHA so that all those products can be empaneled in a standardized way. Third thing, in terms of the financial or some nudges, I think or some financial incentives, we can't pay the kind of billions of dollars which US paid. But that again, in principle decision, I think to support that has been taken. The exact contours, my understanding in the next couple of months itself, should formally be rolled out, wherein kind of some token money, I wouldn't say large sums of money are being given, but at least as a recognition that this is something relevant and important, that should also come in. I think one more lever, or whichever way we call it, we must look at that, is that there are a number of hospitals which substantively, you mentioned about the PMJY levers, etc. as well, which benefit or take a lot of funding from the government as well. So they should probably be among the first ones to start with. They are larger ones, government is supporting them in that context as well. The idea in the end is, like any of us go and we are able to subscribe a Gmail account almost instantly, we don't need anyone's help. So can a doctor, and we wanted to take the example of a rural doctor, so internally we called it Dr. Gupta sitting in Sitamarhi district in Bihar. Can he go on the NHA website, click to download one of the 20 softwares which are listed there, either free or pay very frugal amount of money, less than 500 rupees per month, and is able to configure and start using in less than 5 minutes. The first prescription should be done in less than 5 minutes. I think that's the intent here.
Can you please mute Dr. Jayesh, who is the IMA president? Kindly mute yourself. Thank you.
Yeah. So I think these are some initiatives which are on. That probably, since you brought out those topics, I think it will be good to put it back. But I think let me come back to the core role which I was at. So we'll move on to the kind of the real big expert surgeon on our honorable surgeon on our dais, Dr. Soin here. And I think Dr. Soin, again needs very little introduction. The kind of the leading liver transplant specialist, part of the Medanta, leads the liver transplant center at the Medanta Hospital, a Padam Shri awardee, just extremely distinguished. So I think the doctor community as well, you are kind of a role model for them. So my question for you was, do you, in your day-to-day life as an experienced or a very high-end surgeon in that context, see a motivation to use digital yourself? And in that context, do you think every doctor should do it, or is it just some flip-flap and not really required?
First of all, I'd like to thank NHA and ABDM for inviting me to be here at this very, very important event, and also all of you to have decided to participate. Anything I say is basically going to be for patient benefit. So when I say I find it easier, or the hospital finds it easier, or we have this, or we find that easier, eventually it's going to help the patient get better sooner and with a higher quality care. That underpins everything that we healthcare providers do. The second thing is, if I name a brand, I'm not their brand ambassador. It's just because maybe I'm used to using it. So with those disclaimers, absolutely. I mean, not just me, I'm of course passionate about digital health in general, and I am in a digitized health environment at my hospital, as are many tertiary hospitals across the country and the world. And it does make life easier, simpler for the patient. They're looked after better. Let me give you a few examples. I do liver transplantation. Now, look at the path that a patient who has liver disease has to follow. They had early liver disease. They saw their GP in a tier 2 city 5 years ago. And then they had advanced liver disease, so they went to a tier 1 city, to another hospital, and eventually someone referred them to us. They need a transplant, and after the transplant, which involves a lot of complex ICU level care, they're going to have lifelong follow-up, lifelong follow-up. So you can just imagine this patient has had contact with scores of doctors, scores of labs. They've had reports for years, and all those reports are relevant to me and my team in managing this patient, first of all, to the build-up to the transplant, and then following them up after transplantation. Not just that, this patient may decide that hospital A and Dr. B is not really what he wants, and he wants to switch to another hospital. And he shouldn't have to repeat all his tests or carry, like everyone has said, trunk loads of previous reports. It should all be digitized. So this is the whole point. Just like you can have your bank statement anywhere, anytime, on any device, the AAA, the same AAA should apply to healthcare. And that is what eases life for the patient. Now, this patient goes to ICU. It should be possible for me sitting in another city to be able to know what's happening dynamically, actively to this patient in my ICU in another city. I run 3-4 centers, so it should be possible for me to have on my mobile phone a dashboard which gives me a download of any active report which has happened like in the previous 2 or 3 hours anywhere. And that will help me and my team to look after these patients better, obviously. I'm trying to kind of simplify it so that I connect what we do every day with the workflow that digitization enables. So, in simple words, the patient can carry all his or her reports digitally. The doctor can actually see those reports from before and later on during follow-up. An alternative doctor, alternative hospital can see those reports, and the patient can also have access to their own reports. So all this ecosystem obviously requires digitization. It cannot happen with paper. Let me give you another example. eICU. You have 3 centers doing the same thing. You need not have the same level of expertise in all these centers in the liver ICU. You can have the senior guys in one place. They can actually instruct their junior team members across in another city how to manage these patients. And this is very, very effective. And eICU happens digitally, of course. Now, we have certain solutions like, speech recognition. So I'm looking at my patient. I'm talking to them. I want to maintain eye-to-eye contact. But at the same time, I have to document what the history is and what the patient's complaints are and what my treatment is. So I should be able to actually talk to a computer and do this in a minute or 2, rather than spend 10 minutes typing or employ a junior doctor to do this job for another 10 minutes, which is a waste of a person and doctor. So all this can happen if we are digitized. So, in a sense, the adoption will only happen not just with software solutions and tech solutions, it'll also happen when the doctors are convinced and the patients are convinced that they're actually going to be better off with it. In a country as large as India, where the levels of people range from, the crore level to a paisa level, obviously to have access for everyone to healthcare from primary, secondary, tertiary, quaternary levels, you have to have the ABDM kind of ecosystem. So it's an absolute necessity, and I and my colleagues that I represent are all for it.
Thank you very much. I think
Long answer to short question.
No, thank you very much. That must be very motivating to a lot of doctors who probably look upon you. I think we have Dr. SNP Singh also, who's joined us online. So I hope you are able to hear us. But we can
My request would be kindly be brief. हमें और लोगों के प्रश्न भी लेने हैं यहाँ पे stakeholders के, so kindly maintain that time limit.
So,
Over to you, Dr. Singh. You want to have a specific question for him?
Yeah, so Dr. Singh is the president of the Indian Medical Association. He's also a kind of member of the National Medical Council. registrar of the Bihar Council of Medical Registration, etc. So, Dr. Saab, you represent a kind of, and we were looking at you to represent today a large section of the doctors who either are practicing on their own or running very small clinics of 1 to 5 beds. So, उन लोगों के लिए अगर देखें तो डिजिटाइजेशन से अधिक दिक्कत है या उनको ज़्यादा फायदा होगा? Some words around that from you, sir. So you can unmute yourself, sir. So you'll have to unmute yourself. Yeah, we can hear you.
Ladies and gentlemen, I have to say that Ayushman Bharat Digital Mission is one of the novel initiative of Government of India to strengthen the accessibility of health services and country of development, which is a citizen-centric. Never before the technology was used as effectively in a simplified manner. This will benefit not only doctors and the hospitals to trace and retrack the health record of the patients, but also to make the health record handy to the patients with the complete information. The advantage of ABDM are manifold. This is exactly improve the efficacy and effectiveness of health services delivery system with the complete transparency across public and private healthcare disputes. It makes the data related to the patient's health accessibility to the doctors, irrespective of whether the doctor is in clinic or small nursing home or big hospital. Since the digitally capitalized, the data can assist in the remote area wherever internet facilities are available. With the population of telemedicine, ABDM will provide a strong connect between primary, secondary, tertiary healthcare facilities, where expert advice can be obtained within few minutes. Another important benefit of ABDM is that the entire data can collected directly into the integrated health information platform, which will be useful for research, planning, and public health with the fundings. Like every new project, which will have training from judiciary, the ABDM will also have some problems to start with. The acceptance among the healthcare establishment as well as the aid to the proper. The major concern of the patient as well as the healthcare facilities will be data security and linkage of personal information and medical records to others. If this is taken care of and assured, probably the acceptance of the scheme will be increased to the desired level. Another important disadvantage will be physical discomfort between the doctors and patients. The patients will start relying on digital platform rather than meeting the doctor and discussing their problem. Digital consultation by patient can be added advantage because the doctors can extract the list of signs and symptoms the patient is not able to explain or understand. The symptom has developed whether the patient is required to be examined physically, while the doctors can deliver interval before continuation of treatment. In my opinion, ABDM in present form has a lot of offer to the health of citizens. So it is very good. This Bharat Digital Mission will be good for the patients and the doctor also. I did to told to this Ayushman Bharat, and they have told all the doctors and all the hospitals who registered the Ayushman Bharat mission. Thank you very much.
Thank you very much, sir. That will be very kind. Uh, uh, I think moving on from here, we've got Dr. Tarun Jain with us as well. So Dr. Jain is the award-winning professor of economics at IIM Ahmedabad, and I think he does extensive work around health as well. So I think the main point, I think when I was looking at your profile, which comes to my mind, is that is digital health, does it make long-term societal economic sense as well? Or is it we are just doing again? Because there are many things in digital we do because it's the fancy thing to do, it's the right thing to do. But from a long-term economic standpoint, and we've also seen examples like the US where they had so much money and they spent billions of dollars, and at least some people say that it may not have been very successful. So for a country like India, the way we are doing it, is it likely to bring us long-term prosperity, or is it likely to eat away into that?
Okay, thank you very much for both the invitation to come here and address all of you. And thank you to all of you to come and listen to us. So, I'm a health economist, so let me bring the perspective of the economist, the costs and benefits view of digital health in this scenario, and particularly for India. So here's a little bit of, my view on benefits, as well as perhaps some views on costs. And I'll try to keep my comments short. So first, let me address the individual and the household. And the answer is straightforward. Digital health is a winning proposition, simply because I draw on my clinical colleagues. And they're all saying that clinical care is so much better, healthcare is so much more efficient and effective, so our health is better. So for Indian citizens, health is better, so much more of life is better as a result of our health being better. So, the NHA staff had put up some great testimonials on the screen while the break was on, and if you have not seen those, please hang around at the end of the session to watch the work of the NHA staff, right? And so they're talking about, say, a girl who is completing class 10 from Baramulla because she was able to afford healthcare. And participate in it. They're talking about a rickshaw driver who is able to, recover from a very expensive disease and, benefit from this. So the benefit to the individual goes beyond the clinical benefit. They are able to get an education. They are able to go back to work, and therefore have so much more productive lives as a result of it. What does this mean? So, I have taken a look at some of the unfortunate suicide statistics that have come about. And over the last 30 years, India has grown tremendously. Households across the country have done so much better economically for themselves. But one of the only reasons why households regress economically, go back, become poorer, is because of health shocks, tertiary health shocks, the expense associated with it. And so now, if instead of going doctor to doctor, hospital to hospital for a big disease, they are able to get treatment much more efficiently. The first doctor is able to diagnose them. They are able to get better, and they're able to avoid these health shocks. They are able to avoid all these bad outcomes that happen, right? So I think from the perspective of the household, this is a very good thing. Now, now let me address the provider community, the hospitals, both public and private, diagnostic centers, pharmacies, pharmaceutical chains, so on and so forth. So here, again, it's a key point is more efficient operations. More efficient operations mean that you can focus on what you're good at. You don't need to be struggling around with data, struggling around. So just as the patient struggles with their records, the physicians also struggle with the records. They are also able to, each physician wants there to be better healthcare, and so the hospitals themselves will be able to provide much better healthcare. They're able to move up the value chain. And instead of doing pedantic work, right, which is all not very productive, you're able to move up and do the key care aspects, which you were, wasting time, wasting resources on before. So this also allows you to bring down the costs of care. simply because you're using the available resources much more efficiently. The third community that I want to talk about is the government, right? So there's an unfortunate view that healthcare is a cost. Healthcare is not a cost. Healthcare is an investment. It's an investment that we make in ourselves. It's an investment that through the government we make in ourselves. And so one aspect of the health ministry's good work is that all of us are healthier when the health ministry is so much more effective. But the second aspect of this work is that when we are much more effective, when we are healthier, we're able to work much longer. So think of the 37-year-old who is able to avoid a lifelong disease. Think of the 51-year-old who does not die. And so who are they going to be? Well, the public finance economist in me says they are going to be continuing taxpayers, right? So they're going to continue pay income tax, but they're also going to continue paying GST and all the other things which come back to the government. So healthcare pays for itself. So of course, within government, this requires the finance ministry and the health ministry to recognize each other's good deeds. But I'm sure that this is a task on which the leaders of the health ministry are hard at work and making sure that we are getting a greater allocation towards healthcare so that tomorrow all of us benefit. And in the long run, hopefully, we don't need to see the doctor as much because we're healthier. And so hopefully we'll bring down the cost and pay back to the finance ministry many times more than we ever asked for it, right? So that's my 3-minute view. And so I'll stop there.
Thanks a lot. Thanks a lot. I think probably the applause says it all. Moving to Mr. Rajesh Ranjan Singh, and last but by no means the least in that context, Mr. Singh, he is the CEO of the Wish Foundation. And the Wish Foundation, I think, has been working along with NHA quite a bit as well. And they're doing some great work, particularly on the primary healthcare side. So, Rajeshji, the question which I thought for you was around, again, using ABDM at the primary healthcare end. I think, do we see, and the linkage for that to eventually move to UHC or universal healthcare. So, where do you see ABDM fit in this? Is this, again, something feasible or utopian?
Thank you, Neil. In fact, from the primary health angle, one of the core team members that is sitting right in the middle is, he's the additional secretary. 3-4 years back, when the government of India initiated the health and wellness center component, converting around 155,000 centers, primary care centers, sub-centers into, he was leading that effort right from the front. It's a very clear, and everyone that really talked about, 2-3 things that I really talked. Of course, it also requires about the issue of, the number of tests and everything, papers that you really, that's probably the beginning in the primary healthcare. What is more critical at this point of time from the primary healthcare is the adoption from the provider perspective. The preparedness of the provider to really accept the entire digital, system as a change agent and facilitating kind of, process is something that we need to really work upon as a group, as an individual, and also within the country there. Also, the partly that, if we don't focus on the primary health care from the ABDM perspective, and sir is sitting there, actually you're losing a bigger chunk of the population, because 60-65% of the diseases that you see, it gets addressed at the primary health care level. And somewhere, I was reading a couple of months back that 92% of human health needs can be easily addressed within the primary health care. So if we don't really prioritize, and ABDM doesn't really prioritize the primary health care, and especially this bigger movement which is going on in the country, the Health and Wellness Center, we'll be missing the bigger pieces, and we'll build building the castle without having the base very stronger there. There are, having said that, there is multiple efforts that is going on in the country. Those efforts, the telemedicine, the eSanjeevani one, wonderful, fantastic one. But how cohesive is that with various other actors, players, like, from the corporate, private, everyone has really made that effort in bringing the primary health or bringing the telemedicine into the primary health. So can we really think about having a standard there? And that's something that I believe both Neil, you and Rizwan really talked about, that can we really think about now before it really gets quite late? That's one. Second thing is also on the adoption level, how we really work out in preparing the provider and preparing and building the capacity of the provider to really accept that as a change kind of instrument there. Third thing is also, you can really talk about, Sangeeta ji talked about continuum of care, right? Agnani Sahab talked about continuum of care, but actually where does it start and where does it really end? And Sir talked about the reverse referral. Where will the compliance happen? It will be happening once the patient really comes out within the community or the home setting. Can the digital really be in a way that the continuum of care really gets completed within the home setting, and there exactly the compliance happens? So be it the family, be the caregiver, or the patient himself or herself. How the digital can really be used and be instrumental in actually dealing with that, that's something which we have to really collectively. Last, Neil, just to add to this, I think we talked about, we are a country where sensitivity is very important. We talk about inclusiveness and equity. Can the digital really be used, and especially from primary health? Surely. I think the data can really show you how your primary health behaves, how it really acts. I think that's a very critical element that we should really be thinking when we design those human-centric, the tools and technologies that can really impact the human life.
So thank you. This is the first round we have completed. We know there are still so many unanswered questions which Neil wanted to raise. So what about the patient satisfaction we are talking, but what about the data cleaning, how that system is going to address patient health care is cost effective, but the question is largely upon, is the digital healthcare cost effective? That's very important. And how do we create these referral linkages between primary, tertiary, and secondary, and closing the loop, not with the healthcare facility, but the community level, and what ABDM can play in that role. So ladies and gentlemen, over to you. Questions, please. Please introduce yourself briefly and ask whom you want to dedicate that question, please. Yes, ma'am. Yes, ma'am. Here.
Somebody has the mic? Yeah, but people won't be able to hear it on the other side.
Okay, thank you so much. I'm Dr. Sohaila Kapoor. I have a question from probably the policy makers here. For single doctor clinics who are still using, who still have their own kind of a private practice and they're not using any kind of a technology tool, do we foresee stopping of writing prescriptions by hand and compelling them to use a digital product? Because one very important point which gets raised here is that you cannot gain structured insights from a document by hand. And the handwriting of doctors is a very well-known fact. But the point being, if you want to have valuable PHR data, or AHR, or EMR data, I mean, hospitals are definitely trying to adopt, highly technology-centric tools. But the single doctor clinics are still today writing by hand, which is a problem in the entire continuum of care, right from the pharmacist to the diagnostic referral. So from a policy point of view, are we looking at any sort of mandate coming in there?
So that question was for IMA president to respond initially.
Yes, sir.
He
was
was
actually
asked
waiting.
whether the small clinics or the individual clinics are in alignment with this mission's objective. So I personally feel yes, that should be possible, and IMA president has endorsed it. If we have the entire complete system and we close the loops at every level, in long run, along with the all privacy, security, and other issues being taken care of and data cleaning. I think in long run, it is a good help for them. But Neil can respond on better.
I'll just add one point. So I briefly spoke about these low-cost solutions. So ABDM is working very actively. If you were to go on the ABDM website, on the partners page, there are 9 products today already listed, available to these small clinics and small labs, individual doctor, as you said, the same Dr. Dr. Gupta sitting in Sitamarhi in Bihar, for him to download, install in less than 5 minutes, pay less than 500 rupees per month, and starting to have some of the most advanced technologies, either writing on a pad which gets read by the computer or speech to text. All of those technologies are being added to it so that this group of people don't get left behind. We don't want a digital divide so that the larger hospitals adopt digital and move forward and our individual poor doctors kind of stay behind. That's not the intent at all. So these softwares many of them are actually free. The providers are seeing the benefit the health tech plays, and they're absolutely they're spot on. So look at the ABDM website, they're starting to come up.
Thank you, sir. Do we have a timeline by which we would
Already live.
No, by which we would imagine a policy to come in saying that doctors cannot write by hand anymore and they have to type it out?
There cannot be a policy for doctors not writing by hand. So, but then linking it to detailed health record is something else which we can debate. So, can we take the next question? Yes, there, gentleman behind.
Can we get the mic there?
Can you take the mic fast?
Hi, good afternoon, everyone. Pleasure listening to all of you, and thank you for enlightening us with some excellent comments. My name is Dr. Anunay Jain. I represent Japaigo. I lead the Digital Innovations Unit there. One of the key points that I think Dr. Soin, you mentioned, and Tarun, you also highlighted, was the fact that digital technologies should be able to allow providers at all levels to work at the top of their license. If you go down to the fields today, and I know many of you would have seen this as well. Today, at a primary healthcare level, the highest trained worker, who's the A&M, is digitizing data. The lowest trained worker, which is the ASHA worker, is the one who's doing the counseling and is giving medical information. And the CHO is actually doing the registration on certain complicated applications. I think that entire paradigm needs to shift on top over its head, right? I want to position to the panel if there is going to be a certain allowance that should be made where only a certain type of digital technology should be allowed to then go into the framework as well, right? Because otherwise you're likely to see a repeat of what has happened in the US for 10 years down the lane, where there's $1 billion market that's been now created, which only helps providers digitize data. And having come from that market, having worked in that industry, I'm fearful that that reality is where we will push ourselves into. So would love to have your comments on that.
Absolutely, that's what ABDM has done. It has created that framework without necessarily creating a single app. So the rails have been done, and the individual health tech players are building the cars and the trains to run on them to that extent. But the framework and the standards are completely been designed to that. So I think because we don't have the kind of money US had to pump into that, we're probably not going to go down that path at all. And that innovation is being looked at upfront, which is that in the US government gave a lot of money to the hospitals to digitize. So we are trying to do exactly the reverse, to say that, look, how does the smallest doctor get a product in an innovative way and keep the cost down for that product by providing incentives there, rather than, I think, providing incentive at the far end. I think, so hopefully, I think that's not the road which we're likely to go down that path at all.
Thank you. Yes, ma'am.
Thank you very much, and thank you to the whole panel for this wonderful, insightful discussion. I'm Dr. Deepika Sira, former Deputy Director General, Indian Council of Medical Research. I led the standard treatment development, the SDGs that NHA adopted. And I would like to understand, because Dr. Sangeeta Reddy mentioned it, and I was like, okay, someone is looking at it. I'm very happy, but what has NHA done? They have adopted it, I came to know, but what exactly has happened about creating referral linkages because it was inbuilt somewhere? And also, how is it helping NHA in improving the treatment pathways?
तो आप किससे पूछा ये सवाल?
NHA advisor,
So
name,
referral linkages I can answer. So basically, you know that the Ayushman Bharat PMJ and Ayushman Bharat Health and Wellness Center, the two pillars were started to begin with. And the idea was that we should have a very clear-cut linkages between primary, secondary, and tertiary, and also we should have a reverse referral mechanism which close the loop. So there was a committee set up under the chairmanship of Dr. Manohar Agnani, who sat with along other stakeholders, and they said that there has to be a clear-cut referral linkages between primary to secondary and tertiary. In nutshell, it was that we of course cannot prevent, we cannot ensure the gatekeeper functioning in short term, but there has to be referral linkages at all levels along with keeping these digital health records and ensuring that the services which are available to the nearest possible facility. So individual is mapped to a health facility at the primary healthcare level, and that primary healthcare facility is linked to a secondary healthcare facility which is CSC or the district hospital or the civil hospital, and that district hospital is insured to a tertiary care hospital that includes private hospitals as well at all levels, secondary and tertiary care level. So can we have a system where individual and the system knows very well who is to be referred and where, and seeing a follow-up mechanism ensured. So there are these protocols available in place. I hope that is the answer to your question.
So the protocols exactly is what I made. I mean, along with all the clinical experts and the best minds India has, from the best institutes, AIMS, JIPMER, PGI, all of them. I mean, all of them have put in so much of effort. We've worked so hard on it. And now Dr. R.S. Sharma is also sitting here. And so I would also, I mean, there is so much potential in it for it to be utilized for the referral linkages also. So it starts with PHC, it goes to CHC, it goes to district, and it goes to tertiary. The same disease condition. And also a reverse follow-up, as we have been talking in this panel and as Dr. Sangeeta has also been talking. So if it can be utilized also for the two arms to be linked, it would be great to see.
Yes, thank you. So, thank you. Next question, please. Yes, sir, please.
Yeah, hello.
Kindly introduce yourself. Yeah.
Yeah, I'm Dr. Vikrant Rathod. Thank you all the panelists for the really insightful views. So I do understand from, as the speakers, multiple speakers said, that the value proposition of digital healthcare is fairly clear. And my question was more regarding that, shifting to this digitization for doctors especially is a behavioral change. And as we know, for doctors, kind of taking up any major shift in behavior is a little difficult. So my question was, how do we accelerate that behavioral change so that the digitization can come up really quickly? And is it only a matter of value proposition and policy, or something more can be done? Thank you.
Doctors are very driven by anything that makes it possible for them to treat their patients better, believe it or not. That's what 99.9% doctors want. So when I understand that I can actually manage my patient better by, for example, writing digital prescriptions or using a speech recognition software, then I will adopt it. Now, it's not mandatory in my hospital to do digital prescriptions, but it is mandatory for all prescriptions to be put online. And when I go back after 2 months and I look at my handwritten notes, I'm like, okay, next time I'm not putting in the handwritten notes. I better dictate or I better type it myself. So the behavioral change happens as from experiential episodes. So when you realize that you actually need to go digital to work better and to do better for your patients, that's when the behavior changes. So it's not just like a personal habit, Dr. Soin, stop doing this, start doing this. I think it's experiential, and it's going to happen across the board in the entire medical community, and for that matter, even among the pharmacists and the lab services people.
So before we take next question, the gentleman here on the left is wanting to comment on that, and then Dr. Singh. Briefly, please.
Yeah, I think there's a huge divide on the basis of age. So if you tell anyone under 35 that people write things, they'll just laugh at you. I mean, you know, young people don't write anymore, including young doctors. They all type very fast, very intuitively. So the fastest way you're going to get behavior to change is that, you know, doctors grow up, and you have young people coming out of medical school who've never written anything in their lives, except for exams which they're still forced to write, but everything else they've always been typing all throughout the day and night, right? So that's my point.
Tarun has already covered it, but just an anecdote, a story. We are actually supporting a state government in one of the biggest city to transform their primary health, and they have around 522 clinics there, right? We realized 6 years back when we started this EMR, it took them, actually we didn't find even a single one. One doctor who was retired, he really had a passion to digital, and he became a champion or an ambassador. 4 months, 4 people. 1 year, 20 people. Really, it took us 3 years to really help them, doing a lot of hand-holding, and obviously a certain age group that really talked about. We were very sensitive. So focus went on that age group. And I think last thing that we were struggling 3 years down the line, and we requested government to come out with a mandate. Because they were getting reimbursement, or they were impaneled, they were getting per client 40 rupees. The guidelines came in, or a circular came in, everyone started making an effort. So it's not one strategy that really worked with us over a period of time. And I'm talking about 500 of these doctors who are all trained doctors of all age group.
Thank you.
So I'm going to say something which may become a little controversial, but I'm going to say it nevertheless because I have Dr. R.S. Sharma here. What we've seen globally is doctors are very resistant to change. Now, it may be because doctors in Western countries are probably a little older than we have in a younger country like India. And there are 2 factors that have enabled Western societies to push it through. One is government regulation, where actually nobody has a choice. You have to do it. You know, it's something similar to what the lady was talking about. Can you make, prescription mandatory? I'm not necessarily saying that's a good thing. I'm just saying that in Western societies, a government have had to nudge the system almost to a point where it was not an option for hospitals and doctors through a series of either regulations or fairly significant financial incentives and disincentives. The system was required to move. The second thing that changed was customer preferences. So educating the customer, which is the common man, right, or the patient, to saying what is it that you are entitled to? What is your right to? What kind of benefits are you expecting from your doctor? So I would just request that in the holistic approach that NHA is taking to roll out a digitization of healthcare in India, on the regulatory side, we may have some more constraints in India because it's a poor country. We need to, sort of give time for the system. But if we can also work on empowering patients, empowering consumers through, it will require a fair amount of marketing, evangelizing, etc., where the patient should be asking a doctor after 1 year or 2 years, sir, you're not creating a health record for me, you are giving me a prescription which is not going into my system. I think we have to work on all the fronts because I think there is a class of doctors and hospitals for whom that nudge will be required.
Can I add a little comment? Another aspect is the insurer. Overseas, the insurer insists that the hospital records should be digitized. Otherwise, they will not include them in their accreditation. And therefore, the hospital management and consequently the doctors working there would go digital. So that's another way of doing it.
So next question, please. Is anybody? Sangeeta ji, you wanted to say something? Dr. Sangeeta?
Yes, thank you very much. So just a few brief comments touching on some of the very interesting conversations which are happening. First, I think the strategy of getting the software developers to offer appropriate solutions is really one of the best ways to transform and to make this come faster. So that's a big one. I think there was a very nice question on standard treatment guidelines. So the ability for us to incorporate knowledge or bodies of work which have been happening in parallel with the new structures which are coming in. So the SDGs which were done, and I think, names of Polo, Kiki, all of us worked on this a lot. How do we give this to software vendors and say, put this at the back end of your software packages? On the insurance, that's a very, very important point, and I think almost 9 years ago we spoke with our IRDA about a standard billing format. And IRDA insurance is by and large in line, but when we're talking about that, can we please encompass all other third-party large players, which include CGHS, the PSUs, and other such large players, because we have to do a different billing format for each one of them. So this is a time for cleanup and automation. And when these systems exist, they will accelerate the adoption of hospitals as well as doctors, because I'm assuming that in the next 1 year we will soon have outpatient insurance. And outpatient insurance, which a GP can also practice, with a standard billing format, where you have a high degree of transactions, the need for automation becomes even more. And since everybody's spoken about automation and digital capture, I do want to add that one more single point about the data and data standards. So a few years ago, the government of India took up this concept of licensing snowmen. So because of that, unlike the United States, India will have at least one common set of data standards. Now the adoption of SNOMED is difficult, and therefore we worked with CDAC to say, please create a quick list, because the extent of SNOMED is too much. So again, if the software developers who are here could please understand the quick list and incorporate CDAC's quick list of SNOMED coding into the software. This will enhance not only the adoption, but the quality of data capture. And if you put voice recognition, standard treatment guidelines, and the standard billing formats, as well as the SNOMED coding, these four will be the pillar for us to get very, very intelligent information. Because ultimately, one of the large pieces that we haven't spoken about, which all of us know very well and are waiting for, is after we finish the whole value of the medical and the great value of automation, is the power of the AI at the back end. And the AI value will start kicking in when we have intelligent data collection. So these are the few points I wanted to make, but thank you. I am so happy that we're having these dialogues. This is opening the door for a brave new healthcare scenario, and I very much agree with my previous speaker that we focus on primary healthcare. And if we digitize that and move it forward, and if we empower the individual and put them at the center of care, considering the extent of non-communicable disease and its burden in the country, we need to approach the process from prevention as well as advancement of disease. And this digitization can actually do both. So thank you so much for your attention.
Thank you.
And if I may add the last line, I'm very happy to continue the dialogue. And sorry, on the point of the certification to Mr. Rizwan, NHA actually gave a follower certificate for connecting our backend system with Ayushman Bharat Digital Mission. So the certification system is already there. But if we could have a few more workshops of engagement and understanding, that I think would be very helpful for everyone who's interested in accelerating adoption and registration.
Thank you. So if there are further questions, we still have some time because we can take one or two more questions. Yes, there are two hands, so you can ask your questions. Yes, madam, first.
Sir, just wanted to ask, in terms of digitization, India has been, there's no question of adaptability because we have the highest real-time payment being done in India. So what is the main reason that in India, the healthcare sector, the adoption is so slow?
It's just the beginning. We have started, so you can't ask a question, infant a question which why you have not reached the milestones which adult is required to reach. But that's on the lighter side. You want to respond?
I think, absolutely. I think, but all I'll say is one point to it, the slide which CEO sir showed in the morning, and which I alluded to a little while ago, the pace had started to pick up. Yes, it's a child, but which is kind of starting to grow and run much faster. I don't believe we'll take these normal evolution steps of transaction growth the way it got taken historically or the way many other countries in the world did it. CEO sir said, can we do 1 billion transactions the first year? Why not? I think that's and it seems really possible to be done. There are 6 billion interactions happening annually in the country. 1 billion in the first year of its real growth would be a phenomenal. I don't think any country in the world has been able to achieve. I think at 1 billion level, we will be the largest number of digital health transactions ever recorded in any country, already in 1 year. So 1 year of childbirth, if this is coming in, so let's see how it goes further. So I think that's the hope.
My only additional comment is that healthcare just fundamentally is more complicated. And I don't think we should forget that fact. It's complicated for a variety of reasons. It's complicated because if you look at e-commerce, right, it's very easy. You can build a software where you know incoming inventory, what was outgoing. And so the math behind doing a financial transaction, the math behind doing an e-commerce transaction, very easy. To capture healthcare data, to capture it accurately, to be able to move it around is very complicated. So while we all want things to happen quickly, I think we just have to be realistic about the fact that it will require a lot more stakeholders to get, there's a capacity building problem that we have to train a lot of people. We have to get a lot of organizations onboarded. We have to start to pilot things. Then we have to probably going to have some things we have to learn from the initial set of sort of things that will happen. Most of them will go well, some of them may not go well, so we'll have to correct for those. So I just think that setting aggressive expectations is great, but also recognizing the fact that this is different and this will be more painstaking, I just think is helpful for the industry, because then we don't get demoralized when things take a little longer, or we don't get demoralized when there are few missteps, because we should expect that to happen in a complex healthcare situation. Yeah.
So can we have there are many hands now. So you want to say something?
One point to respond to you. I think there's a recognition that we are at the start of the tertiary healthcare journey. For a lot of what has happened in communicable diseases has been a fantastic journey in India. So if you look at things like dying from polio, or even contracting polio, we will never really experience this anymore. And this has been a fantastic win for most of us. Child's mortality at birth, as long as the birth is taking place in an institution facility, maternal mortality, as long as the birth is taking place in an institution facility, there's been massive declines. So healthcare, won in a lot of those spheres. It's just that now we are going on to our attention, we are aspiring to bigger things, and we are trying to solve much more complex disease conditions, non-communicable diseases, and that's where much of your complexity is coming from. So the earlier solutions that applied to solving many communicable diseases don't easily translate into the non-communicable world. So that journey is sort of starting, but in terms of making progress, I would sort of push back and say there's been massive progress, and I think healthcare in India has been a huge success story. It's just that we are more aspirational today.
Okay, so last. Yeah. Yes, ma'am. Yes, sir.
Sir, I'm Swadeep Srivastav, and I've been into healthcare communications for last 25 years, worked a lot on the preventive healthcare, health awareness side. And I'm first of all, congratulations to National Health Authority for organizing this such an interesting discussion. And today, what definitely is very enlightening is the focus coming back on primary health care. And being into this, sir, one question has been, and I also represent a health tech company, India Health Link now as a co-founder, where we are trying to bring in a phygital wellness module, integrated phygital wellness module to improve the healthcare, primary healthcare infrastructure, contribute there, sir, in some way. So my question is about this health and wellness center, sir. For the last 7-8 years, even from the day the Ayushman Bharat program was launched, there was so much of hue and cry about health and wellness centers, about 150,000 health and wellness centers being put across the country. So some basic questions I'd like to, and if the NHA senior authorities can throw some light and enlighten us on that. Is, sir, first of all, so these health and wellness centers, are these the same CSCs and PSCs which the government is operating, or you're bringing in some new model, additional module, setting up health and wellness center? And are there any protocols and standardization of these centers where players, health tech players like us can also come in and contribute in some ways?
Thank you. So thank you for asking this question, although this subject is not this question is not of this session. I will answer you this very well when we have the tea break, because that's a longish answer to respond to. Please don't mind that. And I have worked in that position, so can respond to that question very well. This is the last question, gentleman here. Yes.
I'm Dennis Streveler. I'm a professor of medical informatics in the States. I've had the privilege in my long career of seeing maybe 30 countries go through this process. And I want to congratulate India on its progress. And yes, there will be some stumbling blocks, that's to be expected, and some false steps, that's also to be expected. But I think there's a period, if I were to look at these countries and generalize, there's a tipping point at which the scenario of digital health becomes part of the infrastructure which is accepted. And that tipping point comes from the patient. When the patient goes to his third doctor and sees them writing illegibly in their notes, yes, my writing is illegible as well, he might say, "Doctor, why are you not using RPHR? Why aren't you digitizing the information that you're providing? Why aren't you giving me an e-prescription? Why is this lab requisition so hard for me to carry to the lab? Why don't you send it to the lab and be done with it?" So it's that awareness from the patient where I think that's what's going to drive that inflection point, if I were to look at other countries. And it's a very powerful kind of buzz. It comes from the citizenry, and all we can do until that point is continue to chop away, one person at a time, one provider at a time, and once we reach that tipping point, then we can be assured that it will be part of the infrastructure in India. And I'm really wishing you all your best luck in reaching that tipping point as quickly as possible. You do that, I think, by informing the public, having use cases which are compelling. I love the liver transplant longitudinal care example in terms of tertiary care. I love the idea of upward and downward referrals from primary care and how they can save lives and make more efficient care. We need to advertise that more. We need to ring our own bell more so that all of India sees that. Once that happens, when they go to the doctor, they will have an expectation that the quality of care is dependent on my doctor using the latest standards and the latest technologies. That's what's happened in many countries, both middle-income countries to high-income countries. And I think it's a very useful subject to consider how to reach that point in India. Thank you.
Thank you, sir. So with that, we should come to an end. Last point, I would say that another important stakeholder, as the Honorable Minister was saying in the inaugural session, is actually the citizens. So we need to do dialogue with the citizens. we must also remember that we will have the patients who are elderly, we will have the patients who are differently able, we will have patients who are children, we will have patients who are illiterate. So all these expectations are to be done by Digital Health Mission, and I am quite sure with the way Digital Health Mission is being envisaged and is going on, we will be impacting on the lives of ordinary citizens through Digital Health Mission. Thank you all for attending this session.
So we have some
session.
awards.
Namaskar, Jai Hind.
Sir, we have some awards right now. So we want to felicitate some of the government institutions and private providers who've managed to actually using ABDM, generate the maximum number of transactions in the last 1 month, sir.
Thank you all for this very engaging discussion. May I also request CEO Sir Dr. R.S. Sharma to join us on stage for the award ceremony. I would request CEO Sir to present the first set of awards in the category of Government Digital Health Solutions or Government Integrator with the highest number of health records linked to Aabhas within 50 days from 1st August 2022 to 19 September 2022. This is awarded to Integrator 2, Reproductive and Child Health, Ministry of Health and Family Welfare, State Representative Mrs. Anjali Rawat, DDG for Ministry of Health and Family Welfare RCH project. The next award in the Government Integrator category goes to National Informatics Center, Ministry of Electronics and IT, State Representative Dr. Piyush Gupta, Senior Technical Director for NIC. We move on to the private sector awards. The award for Private Digital Health Solutions or Private Integrator with highest number of health records linked to Aabhas within 50 days from 1st August 2022 to 19 September 2022 goes to Eka Care, Representatives Sudev Ambadi, Rajat Rawat, and Amit Bharti. And may I request our last award for the evening to be presented to Briefcase Health Tech Private Limited Representatives Shobit Kapoor and Harsh Parekh. Lastly, I would like to request CEO Sir to present mementos to all our panelists present today, starting with our chair, Dr. Manohar Agnani. Mr. Rizwan Koita. Dr. Arvinder Singh. Professor Tarun Jain. and Mr. Rajesh Singh. Thank you all for a lovely session today.